Uh, uh, well, friends, happy World Health Day. And today we are very grateful to Dr. Sanjiv for delivering this special talk. I invite Dr. Neeta Kumar to introduce the speaker.
Thank you, Dr. Bedi. It's an honor to introduce Dr. Sanjiv Kumar, the speaker for today's occasion. He's a alumni of All India Institute of Medical Sciences, New Delhi. After his MBBS, he joined Army as a short service officer. And after serving for 5 years and receiving 2 Army medals, he joined back All India Institute, New Delhi to do his MD in community medicine. And since then, he has not looked back and he has become a very extinguished public health specialist, worked at the local level, starting his career from PHC, Vallabhgarh, and then moved on to UCMS to do his, joined as faculty for 2 years, and then he joined UNICEF. In India, he worked for 10 years, and then another 12 years he spent in almost 33 countries as UNICEF advisor. And then he returned to India with the wish to serve his own country, and he joined as International Institute of Health Management and Research as Dean and later as Director. Followed by, he was invited by the Government of India to join National Health System Resource Center as Director, where he was a major player in National Health Policy 2017 and National Health Research Policy in 2022. He has many publications in peer-reviewed journals to his credit. His main area of interest and expertise is in leadership for health professionals, and he has trained over more than 1,000 participants, and he still loves to mentor many of them who contact him. He is now, after his retirement from UNICEF, he is now busy with his 3-domain leadership foundation, which is under aegis of which he is planning to start again leadership training courses. Thank you.
Thank you, Dr. Bedi, and thanks, Dr. Neeta Kumar. I will suggest when I make a presentation, and if you have any questions, please note down your questions. You can put it in the chat, or you can speak after I have finished my presentation. When I was preparing for this session, I was wondering, do I go through all details of health for all, primary health care, universal health coverage? Then I realized I won't be able to do justice. So I'll be giving you glimpses. But what I'll go into more details is how these goals and various declarations are adopted at international level, because that you don't find in the textbook. And my experience of working in United Nations Children's Fund, I was closely watching how decisions are taken and how these declarations and goals are adopted. Presentation is stuck. Yes. Can any one of you recognize this building? You can put it in the chat box, or you can unmute yourself and tell me what is this building. At worst, you will be wrong, and there is no punishment for being wrong. But make a guess. No volunteers? I see something in the chat. Let me see.
Yes.
Yes. Tushar? Tushar, you are close. Pramod, no, it is not Community Medicine Department of AIM. Tushar, you are close. This is the building. No, Arpita. This is the building. Yeah, some more guesses. Put in the chat box. And I have given you a hint. Tushar is very close to the right answer. Parliament. Okay, another guess. Any other guesses? No more guesses? Okay, then I'll tell you what this building is. This is the building in which Alma-Ata Declaration primary healthcare meeting was held in 1978. And I was in this building on 25-year celebration as one of the 5 UNICEF delegates to celebrate 25 years of Alma-Ata Declaration. The city is no longer called Alma-Ata; it is called Almaty. So the name of the city has changed. So what we will be talking about today is global level initiatives, how UN agenda has evolved from fragmented to comprehensive approach. We will talk about Alma-Ata Declaration of 1978, Millennium Development Goals adopted in 2000, and Sustainable Development Goals which were adopted in 2015. We will briefly talk about the approaches in setting the agenda, who decides. Health for all and universal health coverage. We will briefly have a look at, is it new? Is it something which never existed before, or there was something before? We will also talk about need for whole of population approach to health. We will talk about global agenda set by member countries is good, but how it is implemented. Whatever agenda you have, including UN agenda or also within our country in India, the policies, the declarations are always excellent. The problem comes in implementation, and it is implementation which determines the success. Are we clear about what is health? Then there is a need to address determinants of health for sustainable improvement in health. And SDG gives us Sustainable Development Goals, give us an excellent opportunity. This is to give you a brief idea how UN has historically moved from development agenda in 60s to the latest Sustainable Development Goal. 1960s is known as the UN Development Decade, and it called for accelerated measure to eliminate illiteracy, hunger, and disease. 70s, the second UN Development Decade adopted International Development Strategy to achieve the goals which were set for that particular decade, and it was to achieve minimum of 0.7% of GDP by developed countries to be given as international aid to developing and underdeveloped countries. This was the goal, but this goal has not been achieved by most of the countries even today. Some of the Scandinavian countries, Sweden, Norway, Denmark, they have either surpassed or have achieved this goal of providing 0.7% of their GDP for international development. Then in 80s, we had the new development strategy for the third UN development decade. The second major push was for GDP growth rate for developing countries were targeted at 7.5% and export to be increased by 8% every year, reduction and elimination of poverty, a reduction in mortality rates. 1990s, Rio Declaration of 1992 looked at development and environment. Then you had Universal Declaration of Human Rights. And in the year 2000, they came up with what is called Millennium Declaration. And all of you know, based after the declaration, they had to fix the goal. And they fixed the goals which were known as Millennium Development Goal. There were 8 goals, all of you are aware of that. And these goals were to be achieved by 2015. And in 2010, for a change, they started working on the goals 6 years in advance. 2010, they started working on Sustainable Development Goal and large-scale consultation with people. They consulted 7 million people, individuals and families across the world, which is almost like if you take 7 million out of 7 billion, almost 1 in 1,000 person was contacted to find out from them what do they want. And those of you who want to read more in detail, I have given references to the articles I have written on these two topics, which will give you more insight into how International Development Agenda has moved from 60s to the most recent Sustainable Development Goals. We will spend a minute on this slide. What is the approach? And almost all of you are involved in conferences and meetings where they come up with a declaration. If you have a meeting in Delhi, you come up with Delhi declaration. If in Kolkata, you come up with Kolkata declaration and maybe Goa declaration. Goa will probably be very popular and a lot of people will turn up if you organize conferences and meetings there. So what do they do in these conferences? And earlier they used to do the same in the UN system. They will have some consultation with the countries, maybe in the name of people participation, civil society participation. They will invite some of them and they will have a draft before the declaration. That draft will be shared after 2 or 3 days meeting. They will have a session, which is usually the last session, in which the draft will be presented to the participants. In this case, the member countries. And then the member countries will adopt. And this was the way in which up to Millennium Declaration of 2000, the agenda was agreed. But when they came back after Millennium Declaration to UN headquarters, they realized that how will they measure progress? You have to have some goals and indicators to measure progress on a particular declaration. So a group of experts, chosen few, there was a joke in the UN when we met on MDGs and SDGs, that a chosen few got into the basement of United Nations headquarters in New York and spent a whole day preparing various goals. And when they were coming out late in the evening, somebody asked them, have you included environment? They said, oh my God, we forgot to include environment. They went back and included environment also. This is how the goals were decided for Millennium Development Goals. However, those goals changed the way countries looked at various indicators, and many of the goals were related to health. So health for the first time received more attention than it used to be. Earlier, the health agenda was decided by which agency will decide that agenda related to health? Any guesses? Which UN agency will decide the agenda? Put it in chat box, please. No volunteers? Yes, I have one. Yes, excellent. Yes, I have two answers, Arpita and Johnson Cherian and Pramod. All of you are right. So it was WHO which will decide the health agenda. Who in WHO? Which body? World Health Assembly. You know, the draft will be put to what is called Executive Committee of WHO. Around 30 countries are members of that. And one of the countries chairs that agenda. So that agenda is decided, agreed in this meeting, and then it is taken to World Health Assembly. And after it is decided in the Executive Committee of WHO, it is shared with the member states. They call all the countries and member states. So when they come for the World Health Assembly, they discuss and that's the agenda is adopted. What was different in MDGs and SDG? Any guesses? What was different? Again, I look to many of you are very smart in the group. You have the right answer. How the MDGs and SDGs were different from previous declarations. Yes, Padam Shri also got the right answer to the previous question. Large-scale consultation, Swapnil, yes, that's very good. Anyone else? Community participation. Okay. What else? Any Tushar, community participation is correct. Anyone else? Okay. In Millennium Development Goals and Sustainable Development Goals, these goals were not decided by specialized agency. For example, health-related indicators and MDG. Yes, the World Health Organization has given input. Goals related to children, UNICEF gave input. For UN, for environmental program, UN Environment Program, UNEP gave input. For poverty, United Nations Development Program gave input. So they all gave input, but where was it adopted? Not by with the ministers, it was adopted by heads of the states. And that is what has shifted from MDGs to SDGs. Those specialized agencies give their input, but the agenda is adopted as a comprehensive agenda by heads of the state. And that receives more attention. And you all understand, if your institute's director signs an agreement, and if one of the heads of the department signs an agreement, it will receive more attention and more resources. If it is head of the institution, or in this case, head of the country participates in the discussion and deliberation. And finally, and as you said, there were large scale, not in MDGs, but in SDGs, there were large scale consultations which took place with people, with civil society organizations, etc. Let's now look at the next slide. Yes, another question. Can you tell me what is this picture about? And what are these two gentlemen? You can read the heading of the slide. Who were they? In the chat, I have one response already. Yes, Arpita, intersectoral coordination is very right. In the recent time, we are doing more of it. But 1978, Alma-Ata Declaration also prominently mentioned intersectoral coordination. Any guesses on this picture? You can see the name. This is a tombstone on the grave of Dr. Halfdan Theodor Mahler. Yes, very right, Swapnil, very right. And there were two gentlemen who contributed, mobilized politicians. One was Halfdan Mahler, and second was Henry Richardson Leboy. He was UNICEF executive director. So these two people got together, they mobilized the heads of the state. Both of them had very good convening power. They could pick up the phone and talk to any head of the state. So they carried that political weight, which subsequently, I don't know if any other head of the organization from UNICEF and WHO carried. Maybe from UNICEF side, James P. Grant, who took the agenda on primary health care forward after the declaration of when he became executive director of UNICEF. But somehow UNICEF, yes, Aparna, you're right. Halfdan Mahler was the Director General of WHO, and Henry Leboy was executive director of UNICEF. These are the two gentlemen, and you can't pay a better tribute to anyone. So in this tombstone, it writes health for all for health. This man gave most of his life. He also worked in India for some time in the regional office of WHO, which is in Delhi. And usually looking after programs in India, he contributed to tuberculosis when he was posted here. So he had a lot of experience of how things move at grassroots level and how health should be looked at. So health for all for health. That is what is written on this tombstone, and on top of it, the globe, the whole world represented as a globe. So those of you who visit Geneva or have gone to Geneva can look for this place and remember this great man who contributed a lot to improving health in the whole world. So coming back to Alma Ata Declaration, there were 6 principles which were adopted. Reflect and evolve from the economic conditions and socio-cultural political characteristics of the country and its communities. Because every country will look at based on what resources they have, what situation they have, where do they stand. So that is the one principle. Second is address the main health problem in the community and provide not just curative care, preventive, promotive, curative, and rehabilitative services based on what is needed in that particular country. Third one is involve, in addition to the health sector, all related sectors. And if I remember correctly, Arpita talked about intersectoral coordination. So it started with Alma Ata Declaration that other sectors have to do what they can do to improve role. And some of the sectors they identified include agriculture, animal husbandry, food, agro industry, and other industries, education, housing, public works, etc. And we did an exercise to list the ministries in India which contribute directly or indirectly to health. And can you guess how many ministries? Anyone in the chat box? Thanks, Satinder, for your comment. Anyone? How many ministries? Just give me the number and make a guess. Because if I give you the number, you will forget it after 1 hour. 15, yes, that's a good guess, Tushar. Anyone else? 21, that's getting better, Arpita. Anyone else? 30, yeah. Harini, you are the best so far. We listed 32 ministries. So each ministry has to play their role. Otherwise, for example, in industry ministry, one example is the safety norms. All the seats in the car should have seat belt, which has been made compulsory now. And in 80s, you will remember there were no seat belts even in the front seats. So a lot of accidents took place and a lot of people died. By putting seat belt, you will not reduce the probability of accident, but you will reduce the probability of serious injuries. So then they put the seat belt at the back seat as well. Now the new cars will have 6 airbags. What do the airbags do? They absorb the collision impact, and your body doesn't get hurt. You don't hit the windscreen or you don't hit the side screen, and that's where the airbags give you a cushion. So it's very important we will go into detail later, but it's very important for us to look at what other sectors are doing for health. Promote maximum community and individual self-reliance and participation in every aspect: planning, organization, operation, control of primary healthcare, making full use of local, national, and other available resources. Develop through appropriate education of the communities to participate and take care of their health. Fifth principle is be sustained by integrated, functional, mutually supportive referral system. Primary healthcare is not primary healthcare system alone. It needs to have effective, seamless linkages for referral to secondary and tertiary level care. Very important for us to look at comprehensive healthcare, not just primary healthcare. Rely on health workers, including physicians, nurses, midwives, auxiliaries, and community workers as applicable, as well as traditional practitioners as needed, suitably trained and socially and technically to work with the health team and to respond to the express need of the community. The health system has to be responsive to the needs of the community. These are the principles which were put in place in Alma Ata Declaration. So now from Alma Ata, let's now come to what happened in when Sustainable Development Goals were made. I told you briefly about Millennium Development Goals, how they were developed. But when it comes to Sustainable Development Goal, the first activity they did, if I remember correctly, in 2010 is contact people. They had workshops, meetings with around 2 million people face to face, or go from house to house to do surveys. And 5 million more people gave inputs online. So total 7 million people contributed. They were the first contributor and the most important. And the report for these contribution was called We the People. And you can go to the web and download this report and go through this report what the people wanted. Let us build the most inclusive development agenda the world has ever seen, and that is what was done. It was the most inclusive development agenda with large scale, not only people, they had series of meetings with civil society organizations. They had country level meetings from various member states of United Nations General Assembly. They all gave their inputs, and those inputs were taken. And agencies like World Health Organization led the development of health related agenda. So large scale consultation, and all those inputs then came and they were incorporated into Sustainable Development Goals. And you can read more about it from those two articles I mentioned. They are available free of cost. You can go to Indian Journal of Community Medicine and type International Development Agenda. You will get one editorial I wrote. And then the second article is Millennium Development Goals to Sustainable Development Goals. You will get some more insight into how these goals were prepared. And what did the people say? Good education, better healthcare. Top was education, second was healthcare. Third was job opportunities. Honest and responsive government. Na khaunga, na khane dunga. Honest and responsive government, we talked about. Affordable and nutritious food. Protection against crime and violence. Access to clean water and sanitation. Support for people who can't work. Equality between men and women. Better transport and roads. How does better transport and road help? Get you more jobs. People can go to faraway places where they used to take 2 hours to reach. They can reach in half an hour. And they can find jobs in the nearby cities and continue to work, continue to live in the suburban area or in the villages. With better transport and roads, an emergency can reach a good hospital within half an hour and get care. Even for preventive and promotive care, mother, children, and other vulnerable age groups can reach the health facility and get the care they need. Freedom from discrimination and persecution. Political freedom. Protecting forests, rivers, and oceans. We are bearing the brunt of the environment damage we have done. The average temperature is rising. The snow on the mountains and the 2 poles is melting. Sea level is rising. The temperature of the surface of the sea is increasing, giving rise to effects which are known as El Nino effect, which has health implications as well. Then phone and internet access, action taken on climate change. People also recognize that climate is changing and it is impacting their employment, their agriculture production, their health and other aspects of life. So it was included by people that these were the areas which were identified. Then we got input from the country level consultations and specialized agencies, and that was incorporated, and finally we landed up with SDG goals. We will come to that later. Let's come back to the theme of World Health Organization today. It is health for all. And so we went back and looked at health for all was declared in 1978. And for achieving health for all, what did they say? They said health for all through primary health care, with linkages to secondary and tertiary level. Primary healthcare alone will not be able to give us all the needs required for health for all. So it has to have linkages, but primary healthcare needs to receive most attention. And any one of you can give in the chat box how much expenditure was mentioned in National Health Policy 2017. What proportion of government expenditure should go to primary healthcare? Out of 100, how much? Anybody make guess, make guess. So if you respond, you will remember. If I give you the figure, you will forget. In the chat box, any volunteers? What proportion of expenditure on health government should spend on primary health care? Yes, I have one volunteer. 25, Satinder, Vinod Kumar, 25. Thoda badhao. Any other guesses? I gave you 65. That's very close, John Sancharian. And Vinod Kumar, 60. 2/3 of expenditure should be on primary healthcare. Rock, yes, you're close to the figure which we put in the National Health Policy. What is the expenditure now? Put it in the chat box. How much are we spending on primary healthcare? In the 40 years, Jacinta, Vinod Kumar, 110, Satinder, 25. We are around 50% expenditure is on primary healthcare. So we need to do a lot more. Despite policy coming in place in 2017, we are almost into 6th year. And even today, the expenditure on primary healthcare is not touching where we wanted it to go. So let's now look at, we use these two terms almost interchangeably, but there are some subtle differences we need to understand. Health for all, which is the theme of World Health Organization, health within reach of everyone in a given community. Everybody should have access to health and health care through primary health care with linkages. We talked about it. Health for all is the objective of economic development. And it contributes. You have good health, it reduces poverty. And if you have poverty, it impacts on health. So both these are interconnected. What do we do for ensuring that people have access to health? You need to remove obstacles to health. For example, malnutrition. You have very high prevalence of malnutrition, and last couple of years it has increased in some of the age group. Ignorance. I'm not talking of education. The word used is ignorance. You know, people who are educated, PhDs, also may be ignorant about health. And during my work in the rural areas, I found it was relatively easier for us to convince illiterate people than those who were PhDs and master degree holder. Because if it is a smoker who comes to you, if it is very well educated smoker, he may give you 10 arguments why smoking is good for him. But when you talk to somebody who's not as educated, he will listen to you because you, being a doctor or healthcare provider, know better. He or she accepts what you say. So it is not necessary that you equate ignorance and education. Unsafe water, unhygienic living conditions, deficiency in medical care system. We have to address whatever there are a lot of vacancies on in doctors, specialists, in nurses, in pharmacists, in radiographers, etc., etc. So we need to address what are the deficiencies in the healthcare system. And when we talk of human resources for health, we always look at numbers. You know, it is a tradition that we have, say, 100 positions of medical officers, 20 are vacant. Then we have 30 positions of specialists, 10 are vacant. Then you talk about nurses. Normally, we look at numbers. What are the sanctioned posts and what are the people available in those positions? We need to move beyond numbers. Yes, numbers are important, After the number, what comes? The skill. Do all the people you have in position have the skills required to deliver the services? So first was number, second was skill. Third, what could be the third one? Resources. They have medicine, they have equipment, which they need to treat the patient. And fourth one, you have the first three, but nobody comes to the health facility. There is lack of trust, and trust depends on various other factors. If you go to a healthcare provider, talks to you with respect, you are looked after well, even if you have to wait in the queue, when your turn comes, you are given due attention. And not only the doctor, but every other staff treats you with respect and dignity, you will go back again. In public health system, we are suffering from lack of trust. So even if you have everything placed, more people go to private care provider than they go to the public sector. So keep that in mind. Then the next point on health for all is multi-sectoral approach. Some of you in the chat box said, I look at chat box, I see 4 very less practically, Satinder. We are seeing in practically, absolutely right. Affordability, yes, is also very important. People, if you have to spend money and that money you cannot afford to pay, it becomes a obstacle. And many times we get an impression you have Prime Minister Jan Arogya Yojana, and in which expenditure up to 500,000 is covered. But those of you who worked at grassroots level, PHC or urban dispensaries, know that when a patient has to go to a health facility, if it is a lady of the house who needs to go and deliver in a health facility, what do? She has some cattle to look after. There are some fields to be looked after. This woman will not go all alone. If she has a small child, the child will also go with her because there is no one else to look after the child. Her husband, who does agriculture labor, or if they have land, tills the land and does other thing, he has to accompany her. And what is done usually in rural areas, if the lady of the house has to go, someone else has to come. Her younger sister, elder sister, or sister-in-law has to come and stay at that house when she is gone to hospital. Looks after the cattle and other things in the house. If there are other children, they need to be looked after. If they're old parents, they need to be looked after. That arrangement needs to be made. And then they have to take a transport. The transport also will incur expenditure. The hospital gives free admission to the mother, but the husband who's accompanying her has to make arrangement for stay, has to make arrangement for food. These are the expenditure we normally don't look at, and people always say, my God, we are giving free services. Why don't people come and avail of the services? You need to look deeper. So keep in mind that free service is not the answer. You need, and then, for example, I don't know if that figure has changed. For every mother who delivered in the hospital, she was given cash, 1,500 rupees. That was keeping in mind that she has to incur some other expenditure. So keep these aspects as well in mind. Don't just blame them that we are giving free services. Why are they not turning up for the services? Community involvement is very important, is an essential part of health for all. So looking at universal health coverage is also included in SDG as target 3.8. Everyone, everywhere has access to health services they need. And that service should be provided without hardship. It should include health promotion, prevention, and treatment. Unfortunately, in Pradhan Mantri Jan Arogya Yojana, you have only treatment included. They won't get any free services for prevention and health promotion. And we will look at what are the implications of that. They provide a package of services which they include. And in PMJY, they are always adding new and new packages so that people can get whatever service they need, and the package of services they need is reimbursed by the government to the hospital. People don't have to spend the money. Private sector has become more and more important. I was at a Health for All meeting in IMA headquarters today. And they said in 1947, 92% of people who went for availing health services went to public sector, government hospital, government dispensaries, government facilities. Only 8% went to private. And what was the private sector that time? Small doctor dispensaries, small hospital, or hospitals run by the trust or not-for-profit organization. Not like today where you have corporates coming into private sector. And what will, if I invest 100 crore rupees, what will I look for? I'm a businessman, I'm an investor. I will look for return on money. So, you know, the picture has changed completely now. A lot more people go to private sector than they go to public sector. So private sector, with private sector, regulation of private sector, how much they can charge for which services need to be looked at. Keep in mind, health for all and universal health coverage has not been achieved in any country in the world. So it is a journey towards continuous improvement in health. So you can't say that I have achieved health for all today, but even if today you have achieved, what you do is you identify what services you will provide and which people you will cover. You achieve that. Then you want to increase the number of services you provide. Then you want to increase the number of people you want to reach out to. More and more people should get healthcare services at the cost they can afford. So this one is talking about universal health coverage, improving health status of the population, improving equity. Those who are marginalized, they get services. It needs to reduce unfair differences in health across individuals, social groups, and regions, with focus on improving health of the poor, improving protection of the population against financial risk. Can any one of you give me, I am seeing the chat box has 3 comments. Free services should be accompanied by overall arrangement. Who is this? Let me scroll up. Yes, Satinder, you are very right. The most needed are not able to avail package. Very right. You know, you should always be asking this question, who's being left out? Usually who's being left out is the one who needs these services the most. The web has to be woven around grassroots to highest level institution. You enter at the grassroots primary healthcare facilities, and then you have access. You are referred up or back based on your need. I want to answer another question. How many people go below poverty line because of expenditure on healthcare in India? I want you to take a guess before I give you the figure. Yes, one message. Who's that? 70. Yes, Satinder. 50. Madhumita. 1 lakh families probably. Okay. These 70 and 50 are lakhs or crores? 80, 83. It is in crores or lakhs? Gross reality. 50 to 60 million. You're getting closer, Jacinta. Anyone else? But the figure is still low, Jacinta. I can give you that hint. It is percentage. Okay. I'm asking you absolute numbers. Okay. I will not spend more. 55 million annually. That's closer. 5.5 crore. If I give you the figure, it is close to what you are saying, Pramod. 3.2 to the figures range, because these are estimates, to around 9 90 million. So 3 crore से 9 crore लोग poverty line से नीचे चले जाते हैं because of expenditure on health. And recently it has started improving. Till 2-3 years back, the figure was still going up, and now it has started improving. So we have to keep in mind that healthcare expenditure is one of the main reasons of poverty. And those who are pushed into poverty, they are not able to remain healthy because they can't afford good housing, good food, safe water, and when they fall sick, they cannot go to the health facilities without incurring catastrophic expenditure. What is health? I'll come to you with the basic. All of you are familiar with your definition. Health is a state of complete physical, mental, and social well-being, and not merely absence of disease or infirmity. This is how World Health Organization defined health in 1948 when it came into existence. And nobody knew about health before World Health Organization defined. You will all laugh at it. Well, I've gone to 5,000 years old scripture, Atharvaveda, where it says, Om Pashem Sharda Shatam. I see for 100 years, I live for 100 years, I remain wise, intelligent, intellectually sharp for 100 years. Rohem, I remain well nourished. Pushem Sharda Shatam, Bhavem Sharda Shatam, Bhuyem Sharda Shatam, Bhuyasi Sharda Shatat. It includes the complete well-being, quality of life. Longevity has been defined as an important component in ancient Indian scriptures. Not just disease or mortality or physical, mental, social well-being. Complete well-being is defined in this Veda mantra. So you can look at how you define health. But in practice, what WHO does say in the definition, but in practice, they are always focused on disease and infirmity. What they look at, burden of disease, country-wise, burden of disease increasing, non-communicable disease is increasing. And do they look at mental and social well-being? I'll ask you another question. When you go for medical checkup, you have been appointed as a senior technocrat in the government. When you go for medical checkup, what do they do? Which aspect of this definition? They look at only physical health. They do physical examination, examine if you have any hernias, they examine, maybe do an ECG, maybe do an X-ray, and then they say you are physically fit to join. They don't look at mental and social well-being. So in real practice, the health status of an individual or a population is reduced to physical health. Mental health, we have started noticing recently, but social well-being is not even defined. What are the indicators that you and I are socially well? And then there is another fourth dimension of health they have been discussing in World Health Assembly parallel sessions, and I attended 2 of them. Spiritual health. There is total confusion there because the people they invite to talk about spiritual health usually are the religious leaders, the priests of various religions, and they confuse the religion and spirituality. Spirituality is global belonging. Religion has 2 components, spirituality and what is the other one? You have customs and practices called ritual, religious ritual. On a fixed day, you go to a temple or a mosque or a church. You keep fast on a given day. You say prayers, you do chanting, which differs from religion to religion. So what we are focusing on is spirituality, universal brotherhood. We are all sons and daughters of one supernatural power, you call it God or whatever. And then because we are all sons and daughters of the same father, we are all brother and sister. We relate very well to each other. We take care of each other much better if you have that aspect of healthcare included. And people who are spiritually strong, they recover faster and better from ill health. So we need to understand that the WHO definition of health is not complete. There is a need for revising this definition. And then my question, is UHC new? Globally, we have been talking of universal health coverage from Bismarck model's time, 1883, and various countries have moved in that direction. So globally, we know it is not new. Is it new in India? The first document we had related to health, Boris Committee, and that called for health for all. And then we had subsequent documents talking about government plans and activities to provide health for all. UHC, recent developments in India, we talked about it. There are two components. One is Health and Wellness Center, which will work towards keeping everybody healthy and providing health care to those who are sick closer home. And 150,000, I was told, have already been upgraded. 150,000 sub-centers have been upgraded to health and wellness center. In urban areas, we did not have sub-center. They are putting in place health and wellness centers in urban areas, but the population they will cover is ranging from 10 to 15,000. So they are being put in urban areas. They will provide primary health care, because private sector essentially provides secondary and tertiary level care. We have to keep in mind that if you have to provide primary health care to the population, which is exclusively provided by the government, we need to have more and more of these facilities. And we already talked about free medical care package under Pradhan Mantri Jan Arogya Yojana, which covers around 11 crore families and about 60 crore population. What has been added to urban and rural health and wellness centers, the areas under point B. Non-communicable diseases were not covered earlier. They are included now. Eye and ENT problems are covered now. Basic oral health is covered. Elderly and palliative healthcare services are covered. Emergency medical services are covered, and mental health also been included. This is one slide I want you to understand very well. When you're talking of health, you have to provide health to the whole population. Those who are healthy, you have to make an effort to keep all of them healthy. The population which is at higher risk is more likely to get the disease depending on the risk factor. You have to do health promotion more in this population than you have for the healthy population. Then you have population with disease who are not aware. So you have to screen them. Half of the diabetics in the community are not known to anyone. They don't know they are diabetic, and the health system doesn't know, so they won't get services. They will land up in some complication, and then only they will come to know they have been suffering from these diseases for many years. Population known to have disease, they need to continue health promotion. If you are a diabetic, you are on sugar lowering medicines, anti-diabetic drugs. You also need to take care of your diet, physical activity, cleanliness, etc. No smoking, no alcohol. You need to continue prevention. You need to continue prevention for diabetic retinopathy. Need to go for eye checkup regularly, so that you know before your eyes are deteriorated enough to make you blind. You have to go for kidney function test. Before your kidneys give way, you have to take care of preventive aspects. And then neuropathy and gangrene of your limbs, which takes place, and you are more likely to get infection. So infection prevention measures you have to take care. So prevention continues all across: healthy, high risk factor, population with disease but not aware, and population with disease, they are aware. Compliance is another important factor. Those who are hypertensive, and NFHS 5 has shown, half of them, their blood pressure is not controlled. So we need to make sure that they get regular checkup and their blood pressure is monitored. And we know, let me look at the chat if there is anything. Physical mainly, yes. Very right, Swapnil and Pramod. what we normally look at as physical. I want you to look at this. I'm going to read it out for you. There I am standing by the shore of a swiftly flowing river, and I hear the cry of a drowning man. So I jump into the river, pull him to the shore, and apply artificial respiration and revive him. Just when he begins to breathe, there is another cry for help. So back in the river again, reaching, pulling, applying, breathing, and then another yell again and again. I am busy pulling out people, resuscitating them. Some of them survive, some of them don't survive. The last one is I am so busy jumping in, pulling them to the shore, applying artificial respiration that I have no time to see who the hell is upstream pushing them all into the water. If you focus only on curative care, you will end up spending lot more resources with not adequate results. Some of them you can treat, some of them you cannot treat, some of them die, they have already had complications. So you need to go upstream to see what is causing. These are the social determinants. We need to stop the people or the causes of ill health. This is to give you a glimpse of sustainable development goal. What is the goal? Ensure healthy lives and promote well-being for all at all ages. Unlike MDGs, you were reducing child mortality, maternal mortality ratio, and looking at some disease elimination. We have not given up on those. The three goals in red are the unfinished agenda from MDGs, which has been included in SDG. You have reduced by 1/3 premature mortality due to non-communicable diseases. Usually we look at if anybody dies before 70 with diabetes, hypertension, or other NCDs, we take it as a premature death. So with those with diabetes, they need good care of blood sugar control so that they don't die early, they don't get complications, and they don't die early. Strengthen prevention and treatment of substance abuse. Half the number of deaths due to road traffic accident. They are increasing by the day. From 1990 to 2016, it had gone up 1.5 times. We need to make sure we reduce that. Achieve universal health coverage. We are talking about that in the whole presentation. Reduce the number and deaths due to pollution. And then there are 4 sub-points which cut across the 9 goals we have. And all the sustainable development goals contribute to health goal. You have environment, you have poverty, you have 3 goals related to equity, and you have 2 goals related to peace. All of them contribute to improving health. I worked in Iraq during conflict, I worked in Somalia, and I have seen how people suffer, especially the vulnerable ones, because they don't have access to services because there is no peace. There are fights going on. There are no health workers available, and so on. This is moving to the social determinants there. And where is healthcare? A small box, healthcare. You have general socio-economic and other conditions. Then you have agriculture, food, education, work environment, living and working conditions, and unemployment, water, sanitation, and little box, healthcare and housing. So these factors influence. And if I ask you a question, what proportion of health is contributed by health in India? It's around 10%. 90% of health comes from other sectors. If you have unsafe water, you have any number of health facilities, you will continue to have waterborne diseases. And similarly, if you have vectors, mosquitoes, etc., growing near your household, you will continue to have dengue, chikungunya, filariasis, etc. So we need to look at what other sectors can do. And this is what is happening. Because other sectors are not working, the health sector is getting overburdened. And this, if you can say that this is a doctor who is pulling the burden of disease card and using a donkey to help him to pull this card. The burden disease is so heavy, he cannot even put his feet and the donkey is hanging in the air. So if you do not address preventive aspect, you do not address other sectors contributing to disease, this is where health system will land. The last point I want to discuss with you, family is the nucleus of healthcare for achieving universal health coverage or health for all. This is a publication I saw which had estimated how much money equivalent is contributed by family. This data is, I think, around 12, 13 years old, if I remember correctly. The family contribution to healthcare of the sick is 213,000 crore. And we all know women contribute more when we fall sick at home. They contribute 175,000 crores. Men like me or Dr. Bedi also contribute a little, but our contribution is almost 1/5 of what women contribute. What is the total government expenditure? I took only central government and state government expenditure. I have not taken railways, defense services, etc. That comes to 169,000. So around 170,000 crore, which is less than what family contributes in terms of money. And where is health produced? In the family. Where is agriculture products come from? They come from the farm and the farmer. If health comes from the family, why don't we give the same attention to the family for production of health as we give to the farmers and the field? Give them subsidies, give them good quality seeds and water and other resources so that they can produce more food grain. And we know families produce a lot more health than all the health facilities put together. We don't give it that attention. And if you want to read more about it, there is a publication which is going to come out too soon. It's been accepted and proofread, and you will understand better. Why should we give more attention to family level care, not health care at the doorsteps, the health care inside the family, inside the doorsteps. That is another aspect we need to address. This is one example, life-saving interventions for mother and children. 90% of life-saving interventions for mother and children are done at home. Even when you have to provide treatment in the hospital, for example, a child gets pneumonia, you have to take to who detects the pneumonia, who decides where to go and when to go, again in the family. So we should be giving more importance when we talk of health for all or universal health coverage to what happens within the four walls of a family. Good policy, we are very good in making excellent documents, but the problem is implementation. And we never look at evidence in implementation. We never look at reaching out the last beneficiary. Accountability and implementation framework in every health program is missing. The person who is accountable, either the doctor or the ANM or the grassroots level function, they are immediately terminated if something goes wrong. If there is a death in family planning camp, the surgeon is terminated or CMO. But what about those people who are to provide them resources? What about those people who are supposed to give them training? They are never touched. Where will these people be? Either bureaucrats or higher ups. They are never. So we need a proper accountability and implementation framework, and implementation research needs more attention. Thank you. Now it's time for questions. So you want to access I am on Gmail, I am on Twitter, and on Facebook. You can connect with me. I am also on LinkedIn, and I also write a blog. You can look at Dr. Sanjiv Kumar .wordpress.com and you will get to the blog. I have written about 50 articles related to public health, but most of them are related to leadership. And through this organization, we have partnered with MOU. Maybe Dr. Bedi will announce after we have finished the discussion. There is a course coming up in June, which will be on leadership for public health professionals. So we are targeting public health professionals, but leadership skills are the same for clinicians, for academicians, and for people even outside the health sector. So let me look at the chat if there is any question or comment. Implementation is lost as making us sitting in the AC room. They're those who are planning. No, I will not undermine those people who are doing the planning. They are, the best brains available to us in India and even from international agencies. But the problem is in implementation. We do not give sufficient resources to the people who are implementing. The infrastructure probably is not adequate. There are bottlenecks in implementation, and we fail the public in implementation. Now to work on reducing out-of-pocket expenditure in rural areas, very important, Tushar. Recent evidence shows that the out-of-pocket expenditure in last couple of years has started going down. Should we have a needs assessment of families itself as a program? Excellent. You hit the nail on the head, Johnson Cherian. There is a community-based assessment pro forma available, and we are looking at that both in urban area and rural area. When I teach leadership and management, I always give example of the best manager I have seen in my life. Who's that best manager? Any guesses? Quick guesses? Yes, Dr. Sanjay Kumar. Thank you for sharing this. Who is the best manager? The housewife. She does assessment, who eats how much, or even if she does not assessment, she knows who's going to eat how many chapatis or how much rice. She prepares the same amount. So we need to do similar assessment for healthcare services, and that will happen when we have access to every household. And these days they are working on digital health record for the family health record, which will also have individual health record. And with NCDs coming in, people will live 30, 40, 50 years after they get hypertension or diabetes. But they will forget after 40 years which medicine was given to them, which medicine was effective, which medicine had side effects, and so on. If you have a complete record through National Digital Health Mission, you will be able to keep all that record. Yes, Kakoli Bandyopadhyay, you are very right. There is many times duplication when the programs are being planned. What is the problem? The program managers at the state or central level, sitting in their room, they constitute an expert committee and they make a program. They do not talk to the other program managers. Some of the elements in the program may be covered by other programs. So there is a need for synergy. And that synergy will come when you go down to lower level, when you're looking at family health record, when you're looking at providing services to the family, you're looking at family health needs, you're doing community health assessment, you will come to know of those needs, and you can make the program to meet their requirement. Great. Let's bridge the gap between reality and results. Yes, Satinder, that is very right. But how do we do that is very important. You can do it better when you give the maximum importance to the people who are working at grassroots level. When you have planning meeting, there was only one meeting I had organized in Rajasthan on immunization, where we had A&M sitting next to the principal health secretary to give inputs in the planning. So we need to talk to the grassroots level functionaries. They know grassroots realities much better than I and you know. So it's very important to turn the pyramid upside down and give more hearing to what the grassroots level functionaries want. Too much political interference is happening. In fact, yes, this is a very important aspect. Padam Shri Yalaman Chili. This is a very important aspect. In the training course, we will discuss how do you deal with political interference. You never say no to them. There is a saying in Sanskrit, Satyam bruyat, prem bruyat, na bruyat satyam apriyam. Prem cha nanritam bruyat, isha dharma sanatana. You will hear this again in the leadership training if you join that. When you talk to politicians, speak to them very sweetly. And if you are 100% sure what you are saying is right, even sweeter. But the second part of it says, if there is something wrong, speak up, but that again, very sweetly. not speaking the truth or not saying what you want to say because something is wrong is again as bad as telling a lie. So we will look at that aspect. I still have comments coming in. Our class 3 are because absolutely Satinder. When I was working in Rajasthan at the state level, I used to go to the field, get pictures only of male workers and A&M. Most of the time it was A&M. I will take their picture, and there was a magazine Niramaya. Those of you from Rajasthan may know that. In that magazine, I used to devote one page to this worker and talk about it, ask her what messages she has, what help she needs. You know, these are the auxiliary nurse, midwife, the grassroots level functionaries are the backbone of our system. If you talk of immunization coverage, medical officer has not given even one dose of vaccine. The district immunization officer has not given even one dose of vaccine. It is the auxiliary nurse with midwives and others who give the vaccine. Let's give them due recognition and due support. You cannot promote them out of turn, but you can at least give them recognition, give them award. Ask them to appear when you have a press briefing. Put the A&M in front of the press and tell this is the lady who has done all the work by immunizing children. So very important for us to encourage class 3. And you will also learn about how to motivate your staff in the leadership training. What I used to do is when I used to go to a PHC or sub-center, I will ask the A&M, how many children have you vaccinated? Tell me the rough number about full. No, sir, I vaccinated so many, I don't have an idea. Then I look at her register and dig out maybe you vaccinate about 100 children in a year. So in 1 month, so it will be 1,200 children in a year. How long have you been working? 1,200 into 10 years, it's a 12,000. So if you vaccinate 1,000 children, you save 3 lives. Then I asked the people around her, if you save 1 life, where does the God, Christ, Prophet Muhammad take you? Or Yam take you? Everybody will say, sir, take us to heaven. Either this lady has saved hundreds of children. I give them exact number. From 12,000, 3 per thousand, she has saved 36 children already. Where will she go? And then I joke with them. The Yam will come in a decorated jumbo plane and take her in the jumbo plane with all decorations to heaven. So, this is the way you can encourage. When I make this statement, I have seen eyes welling up of the A&Ms and saying that, sir, nobody ever talked to us. Everybody comes and finds fault with us, shouts at us in front of the villagers. We lose respect in the eyes of villagers. So make sure that in your interaction as a leader, you give them recognition and at least motivate them to do the good work they are doing. Thanks, Satinder Pal, for raising this important aspect. Anyone else comment or question? Back to you, Dr. Bedi. Are you there?
Yes, sir. I'm
You
there.
can announce the next course and any other announcement you want to, or any comment or suggestion on
Yes,
the
sir.
session
Yes.
we just completed.
Thank you, sir, for this enlightening talk on the very auspicious day when Health for All has been declared as the theme for this year. And of course, in 21st century, the kind of resources available are much more than which were available at the time of our Almaty declaration. And India also is trying to do its 2 cents towards this overall goal by coordinating all the stakeholders. Dr. Sanjeev has come up with a course on health leadership. Sir, can I show them? I have placed a link in the chat box. You can click on it and
Have you been able to access the link?
I'll just, sir, if you, I'll share the screen now. You can stop sharing. Yes, this is the course. And so this
You
is,
can also ask others who are interested to join this
yes,
course to register.
yes,
Sorry, Dr. Bedi,
those who are not
Go
in
ahead.
public health, in community medicine, they can also join, as it is a general purpose leadership course in healthcare. And there is a sir has kept a very tiny fee for this also. And the topics to be covered are introduction to leadership, concepts and theories of leadership, health, diplomacy, basic skills of leadership, scientific writing and evidence to policy and related skills, and of course, review of personal leadership development action plan, and finally conclusion. Dr. Neeta is the another resource person for the same. So those who are interested, they can join this course. I'm sure this course will be under Dr. Sanjeev's vast experience and leadership. It will spread all over India, and the knowledge for this will be applied where it is actually needed, from top to bottom. So I can see some more comments coming. Yes. The
Dr.
session
Bedi, they
timing,
are
the
asking for
session
the
timings
recording
are
of this
always,
session. Sorry,
yes.
I interrupted you. They are asking for recording of this session.
Yes, this session will be given. Yes, that will be provided.
Oh. Let me tell you a little about the approach to training. I did my MBA at the age of 53 when I realized I was not trained in leadership and management. So I did my MBA from University of Wales in UK. And during the training, I had a course on applied leadership. And I was totally confused. I read more than 100 articles and 6 books on leadership. I didn't know what was in it for me. Then for 1 week, I stopped reading and then put my thoughts together and came up with what was later on published as a 3-domain model of leadership. And that is the approach I have been using. I have trained about 1,000 plus professionals from healthcare, various categories. And that we find very useful. Those 3 domains are self-domain. You cannot be a leader if you cannot lead yourself. Discipline, emotional competencies, prioritizing what you need to do. I call it first thing first. I don't call it time management. The second one is managing your team. You are also managing a team and in the family. You are all looking, you and your wife and others are looking after your children. So that this training is not just going to help you in your professional work, going to help you in your family relationship building relationship with your friend. And the third domain is lot of things in healthcare are changing because of technology application and changes in external environment. Epidemiology is changing. Technology is coming in. Telemedicine was not as important 2 years back before COVID, but it's become a lot more important now. You have teleconsultation. You don't have specialists in the district level. You can connect to any specialist in a medical college. So it's going to address shortage of specialists in a big way. And similarly, working, you're a lot more comfortable in attending virtual sessions like this one. You can also have team members who are not with you physically, working at a faraway place, but you can meet with them every week, discuss what are the issues. So there is one of the blogs I have written on working with virtual teams. When people are not with you physically, how do you work with them? So there are many aspects under these three domains we will cover. And let me also tell you, because these six sessions will give you beginning. You will start your journey. And we strongly believe, me and my co-director, Dr. Neeta Kumar, you can start leading from anywhere. You are MOPHC, you can lead from there. You are assistant professor, you can lead from there. You are a junior resident, you lead from there. You are a senior resident, you lead from there. So you start leadership skills at whatever level. Don't wait for yourself to becoming head of the team or head of a department or head of an organization. You start building your leadership skills as you move up, but you have to start practicing them. You can start practicing emotional competencies, for example, in with your children. Children at times are very annoying. If you're emotionally competent, you don't lose your temper. You manage the difficult behavior of the child in a very emotionally mature manner. So this is how I look at it. But those of you join, you have to see, because the taste of the cake is in eating. I can do a lot of things, but if you join, you will learn more. This is the first course. Then we will have subsequent courses, intermediate course and advanced course. And then we will, based on the input we get, maybe have specific sessions, one session or two session on particular aspect, which you feel you need to know. And what we normally do is, after the course is over, we keep a WhatsApp group with the participants who have already been trained. They keep raising issues. So this was never discovered. So this was never discussed, and we need to have more. So we can start looking at short capsules of training, depending on the need which comes from participants like those who attend this course. Back to you, Dr. Bedi.